active, very much dedicated surgeon. I hope you are going to stay a very good session with Professor Nassir Alhaboob.
طيب بسم الله الرحمن الرحيم. في البداية بشكر الأساتذة الكرام الأساتذة الأفاضل على حضورهم وإعطاء الفرصة إني أقدم. برضو أنتهز الفرصة إنه أشكر الأخ محمد عباس والأخ رامي على الجهود المبذولة في تقديم المحاضرات. And this is time to start one of the major topics that I've tried to summarize it regarding portal hypertension. Just few points regarding the anatomy of the portal vein. And as we know, the splenic vein is joining the superior mesenteric vein behind the neck of the pancreas to form the portal vein, which is further divided into right portal vein and left portal vein. And the inferior mesenteric vein joining the splenic vein before forming the portal vein. And there is another tributaries like an umbilical vein that joining the portal vein before bifurcation. The portal vein is approximately 8 to 10 centimeter in length in adult, and with a maximum diameter that range between 10 to 13 millimeter. And there is 5 areas of portosystemic shunt in the lower esophagus with upper stomach between the esophageal veins, the azygos and the left gastric vein, and behind the liver in the bear area, and the area of around the umbilicus between the epigastric veins and the paraumbilical veins, and the retroperitoneal area between the lumbar and colonic veins, and the important one between the superior rectal vein and the inferior rectal vein. So before going further in this major topic, just to have some definitions, starting with portal venous pressure is the blood pressure in the hepatic portal vein, and which hepatic venous pressure is used to estimate the portal venous pressure by reflecting not the actual hepatic portal vein pressure, but the hepatic sinusoidal pressure. The hepatic venous pressure gradient means is a clinical measurement of the pressure gradient between the wedge hepatic venous pressure and the free hepatic venous pressure, and thus is an estimate of the pressure gradient between the portal vein and the inferior vena cava. If you just look for this diagram, the wedge pressure is a catheter that inserted through the jugular into the superior vena cava, through the heart into the inferior vena cava and the hepatic vein, and when the catheter had end balloon inflated, it measured the wedge hepatic venous pressure, and when it is deflated, it measured the free hepatic venous pressure, and the normal hepatic venous pressure gradient is nearly 3 to 5 millimeter mercury. The normal portal pressure varies between 5 and 10 millimeter mercury, which is nearly equal to 7 to 14 centimeter watery. So portal hypertension is defined as a portal pressure gradient greater than 5 millimeter mercury. To know the pathophysiology of portal hypertension, we have to look for what we call it Ohm's law, in that pressure is equal to blood flow times the resistance. So whenever there is increase in the portal flow and or increase in the resistance, these both of them will lead to increase in the pressure. And this is a basic knowledge of the portal hypertension. In generally, the causes of portal hypertension, if you just look for this diagram, consider this is the spleen, and this is the splenic vein, and this is the portal vein, and this is the liver with the sinusoid inside, and this is the hepatic vein, this is the inferior vena cava, and this is the heart. The causes could be pre-hepatic, hepatic, and post-hepatic. If you start by the pre-hepatic cause, ranging from the splenic, for example, any causes that leads to increased blood flow, for example, like idiopathic tropical splenomegaly or arteriovenous fistula, this will result in increasing the flow, so it will result in increasing the portal pressure. The other causes of prehepatic, like splenic in the splenic vein or portal vein, like thrombosis or invasion by a tumor, for example, or compression from outside by tumor, by lymph node. And at this point, another causes that can cause portal vein thrombosis, for example, those patients with the portal emphysema as a result, for example, as an acute appendicitis or umbilical vein sepsis like that, those patients as a feature of portal vein thrombosis. And I don't want to forget another cause, like those patients with a pancreatitis have a more attack to have a portal vein thrombosis. Another cause of hepatic, and if you just look for this diagram, this is the portal venule, and this is the central vein connecting between the sinusoid. It is further subclassified into pre-sinusoidal, sinusoidal, and the post-sinusoidal. The commonest example of the pre-sinusoidal is schistosomiasis, and other causes like early primary biliary cirrhosis, or chronic active hepatitis, or congenital hepatic fibrosis, sarcoidosis, or toxins like vinyl chloride, or idiopathic portal hypertension. All these are causes of pre-sinusoidal. The commonest cause of sinusoidal is liver cirrhosis, and the other non-cirrhotic cause like acute alcoholic hepatitis, or cytotoxic drugs like vitamin A intoxication. And the causes of the post-sinusoidal, like a veno-occlusive disease or alcoholic central hyaline sclerosis. If you move forward from the post-hepatic cause, it can be range from the hepatic veins or inferior vena cava or the heart. If you're looking in the hepatic veins, either the small or large, it could be veno-occlusive disease or thrombosis or web or tumor invasion or Bucchiari syndrome, or in the case of the inferior vena cava, again, like a webs, tumor, invasion, or thrombosis, or if the cause in the heart, the commonest one like a constrictive pericarditis. So this is just a general causes of portal hypertension, and I'm going to concentrate mainly on the schistosomiasis and cirrhosis. So going to the pathophysiology of portal hypertension. In general, portal pressure are regulated by changes in the hepatic vascular resistance, which is normally under control of neurohormonal control or a portal tributary blood flow. So the neurohormonal or the blood flow can control the portal pressure. And there are two theories in the pathophysiology of portal hypertension have been proposed. The first one is a backward flow theory, in which a portal hypertension is attributable to increased resistance to portal venous flow, or forward flow theory, in which increased splanchnic blood flow maintains portal hypertension despite extreme portosystemic shunt. The sinusoidal abnormalities caused by accumulation of collagen the perisinusoidal space of this may induce increased resistance to blood flow in various pathological conditions of the liver. And if you consider this a diagram showing the liver, and this is a liver lobules, how it looks like, and this is a single lobule, just magnify one or cross-section of this liver lobule, you can see this is triad containing a branch of the hepatic artery and the portal vein and the bile ductules. And at this point, I would like to mention that the liver supply is coming 80% from the portal vein and only 20% from the hepatic artery. This portal vein with the hepatic artery join together to form a sinusoid which draining directly to the central vein. And this is the bile canaliculi that join together to form bile duct and ductules and duct. This is a hepatocyte lying between all of these. And if magnify more and more, again, this is a bile duct, this is a portal vein, and this is the hepatic artery, and this is the sinusoid, and this is a hepatocyte between each other. Looking for this one in the right one, we can see this is the sinusoid with endothelial cells, and this is the space between this sinusoid called the space of this. And this space of this containing stellate cell, and I'm talking about it later, these cells play a good role in the distortion of the sinusoid that result in more and more resistance, and so portal hypertension. The most common causes of portal hypertension worldwide cirrhosis, but among Sudanese patients, schistosoma is the commonest cause. And the increased resistance is mostly caused by hepatic architecture distortion as a result of fibrosis and regenerative nodules, especially in cirrhosis. An increased resistance caused by intrahepatic vasoconstriction, and this is a result, as I mentioned before, from the cell that found in the space of this, like stellate cells or myofibroblast. And these cells, when activated, result in contraction and distortion of this sinusoid, in addition to the vascular smooth muscle cell and the portal venule, which mediated by increased endogenous vasoconstrictor like endothelin, or reduced nitric oxide activity. So when resistance increased, portosystemic collaterals develop as a consequence of the high pressure in the portal vein to minimize this resistance. However, even when the portal flow is entirely diverted through the collaterals, portal hypertension persists because of the concomitant increase in the portal venous inflow, which is caused by splanchnic vasodilatation. So going to the presentation of portal hypertension, and usually the presentation is varies. If we start with the commonest in Sudan, for example, those patients have esophageal varix, they can be presented with hematemesis or fresh rectal bleeding or melena, or sometimes the patient can present it with left hypochondrial pain or dragging pain or swelling for splenomegaly, or can present it with abdominal distension due ascites. And sometimes those patients have a renal impairment, which is caused by hepatorenal syndrome, or for other causes, this patient can have an encephalopathy, and they can present with altered level of consciousness or even coma. And other feature, what we call the stigmata of chronic liver disease, like a jaundice, gynecomastia, testicular atrophy, spider nevi, fetal hepaticus, etc., or liver flabbing tremor, etc., etc. So starting by the 5 major one, ascites. What is the theory behind ascites? As I mentioned before, due to distortion of the sinusoidal architecture as a result of activation of stellate cell and myofibroblast and deposition of collagen, this will result in increase in the hydrostatic pressure. So increase in the hydrostatic pressure will lead to splanchnic vasodilatation, and the splanchnic vasodilatation lead to effective arterial volume decreased. So the blood decrease, which results secondary in activation in renin-angiotensin system. This will result in activation of aldosterone, which have a vascular volume increased. And when the vascular volume increase, more and more hypertension. And in case of increasing volume of the vascular volume, some of this fluid will be extravasated out the extracellular fluid, which can cause ascites. If you can have, just look for this simple capillary bed. This is the arterial end, and this is the venous end, and this is the lymphatic with the lymphatic thoracic duct that end on the left subclavian vein. At the end of the arterial end, as we know, there is increase in the hydrostatic pressure. The increase in the hydrostatic pressure will lead to all fluid can be, or not all, a lot of fluid can be extravasated outside the vessel into the interstitial area. So it is not intravascular, it's extravascular fluid. And this fluid, by the action of plasma colloid oncotic pressure, will come back to the circulation. Minimum of this fluid cannot return back to circulation and stay in the interstitial region, but can be transmitted by the lymphatic, so coming back again to the circulation. In the case of portal hypertension, the increase in the, as we know, for example, in cirrhotic liver, there is low albumin and protein, so there is increase in the hydrostatic pressure due to the resistance, and despite that, there is very low level of albumin, so the fluid is extravasated outside the vessel in the interstitial. Minimum of this coming back, and some of these go through the lymphatic into the lymphatic duct, but because the hydrostatic is more than the oncotic colloid pressure, this fluid can accumulate in the interstitial space to form the ascites. And this fluid, if it is in the peritoneal cavity, form ascites. This pathology occurs on two levels: the level of the sinusoid, and when the fluid is over the retaining back, some of this fluid accumulate in the peritoneal cavity to form the ascites, and at the level of the lumen, of the wall of the lumen of the small or large intestine, the fluid accumulate in the lumen that result in congestion of the wall of the lumen. So, in a case of for example, sinusoidal distortion due to splenic, due to cirrhosis or anything, in case of cirrhosis, there is two pathways: either the reduced albumin, as I mentioned, that result on reduced plasma oncotic pressure and directly can cause ascites, or in the other cause, cirrhosis or other, there is increased intrahepatic vascular resistance due to sinusoidal distortion, and this will result in increased portal venous pressure, which result in reduced effective intravascular volume and again activation of renin system, and this will result in activation of aldosterone and more sodium and water retention and more ascites. In the other way, in the case of increased intrahepatic vascular resistance, there is activation of nitric oxide, which result again in reduced effective intravascular volume, and the circle will complete back again to more ascites. So the component of ascites containing few leukocytes and RBCs and containing low protein, usually less than 2.5 grams per deciliter, and the serum albumin acidic gradient is the difference between the serum albumin in the plasma and the albumin in the acidic fluid, usually is more than 1.1 gram per deciliter and has an accuracy of 97%. The management of ascites is ranging between simple dietary control by sodium restriction to 1.5 to 2 grams per day. And sometimes we need to use diuretics like potassium sparing spironolactone or Lasix, plus or minus Lasix. And in certain conditions, an arginine vasopressor receptor antagonist like citalopram can be used. If ascites is persist despite all these measures and recur for more than time, this is called a refractory ascites. And in case of refractory ascites, The management can add it either by paracentesis, either directly or through ultrasound guided, with or without albumin to prevent reaccumulation. And if failed, they can move to TIPS. And in certain conditions, not usually used now, is a peritoneal venous shunt, like a living shunt. And the living shunt is just a catheter put in the peritoneal cavity containing many holes and connected to valve, and it runs in the subcutaneous tissue to join the jugular to the superior vena cava. And the aim of this is just to transmit the all fluid through this catheter into the systemic circulation. And again, in the case of refractory ascites, liver transplant can be of benefit. Possible complication of this ascites is what we call it hepatic hydrothorax, and it's pleural effusion. They thought that the theory behind that could be small holes in the diaphragm, or could be of lymphatic drainage. And the other possible complication is a spontaneous bacterial peritonitis, which is gram-negative aerobic bacteria. And at this situation, we have to differentiate spontaneous bacterial peritonitis from a secondary peritonitis. The difference is just by taking ascitic fluid. And we found there is, as we mentioned, low protein, low glucose, and low LDH. The second presentation of patient with a portal hypertension is esophageal varix. And in esophageal varix may be asymptomatic and can present sometimes with acute emergency situation like hematemesis or bleeding or melena. And it has a very high mortality rate, and usually the diagnosis by endoscopy. And the aim of management is, for all patients with varix, is to prevent formation of esophageal varix in the early diagnosed patient with portal hypertension, and to prevent bleeding for those patients who diagnosed with esophageal varix, and to control bleeding if the patient has esophageal varix and have an attack of bleeding, and to prevent recurrent attack of bleeding of esophageal varix. This is the aim of management in esophageal varix. So the most widely used in the case of elective is non-selective beta blocker, and the commonest one is propranolol and nadolol, and is associated with a median reduction in hepatic venous pressure gradient of approximately 15%. And the management of varices is ranging between esophageal band ligation and esophageal sclerotherapy. And to compare it between combined therapy and single therapy, in a case, for example, of esophageal variceal ligation plus beta blocker, or to use a beta blocker alone, they found that the combination therapy of esophageal or endoscopic variceal ligation plus propranolol is more effective than propranolol alone in the prevention of the first variceal bleeding in patients with liver cirrhosis. And the management for those patients with acute esophageal bleeding, starting by admission and IV fluid and blood transfusion. And usually in our institute, the blood transfusion usually not given until it's less than 8 or 7.5 grams, because the theory behind that is high blood is associated with high pressure and high rebleeding and high mortality. And all patients, they receive a glybricine if there is no contraindication, usually with a bolus dose of 2 milligrams, followed by 4 to 6 hourly 1 milligram. And antibiotic is controversial in a lot of papers, and those who suggest to use an antibiotic, they thought that antibiotic will reduce infection, and an infection is associated with a recurrent bleeding, and of sure vitamin K and fresh frozen plasma as per needed. And the blood pressure should be controlled in a range, for example, systolic pressure between 90 to 100 or 90 to 110. And if you have a central venous pressure between 9 to 16 millimeter mercury. So if the bleeding is persist despite all these measures, the second step is what we call pylon tamponade, like a simvastatin, which is common in Sudan. And let me just to talk few points regarding the mistaken Blackmore tube. It's inserted either through the nose or the mouth. We prefer to insert it through the nose. And it contains three ways. This is for the gastric balloon, and this is for the esophageal balloon, and this is like an NG tube. This is for suction drainage from the stomach because the terminal ends contain holes, and as we see in this picture, it inserted through the nose down to the stomach, and at this stage, I have to confirm that this tube is inside the stomach by just inflate air, and here by stethoscope. Then I have to inflate firstly the gastric balloon up to 200 to 250 ml. And when be sure that it's inflated, then the second step is to pull it out and fix to the area of the nose by plaster, by anything. Then to inflate the esophageal balloon, and the esophageal balloon should be inflated by millimeter mercury is nearly 30 millimeter mercury. Not more than that because the pressure in the lower esophagus nearly 40 millimeter mercury. If the pressure is exceeding that, this will result in esophageal perforation. So when connected both of them, the other lumen should be connected to urine bag, then to observe if there is any blood inside the stomach. And please, if you insert a mistaken tube, please keep it for at least 24 hours. But in these 24 hours should be both balloons deflated every 4 to 6 hours to avoid, for example, the esophagus one. If it is inflated for more than 6 hours, this will result in mucosal ischemia, mucosal ulceration that end by mucosal perforation. After 24 hours, if you have a setup for emergency endoscopy, so we prefer to remove this tube inside the endoscopy unit, and the endoscopist is ready to insert the scope, looking for the site of the bleeding and manage. But in the case, if you are far away in an area, there is no available endoscopic unit, so I prefer to keep it, to deflate it after 24 hours, and to keep it inside like NG tube, just looking for the gastric secretion. If it contains blood, it's easy to inflate both of them. If it contains no blood, just keep it for another 24 hours, and then you can send patient and you can remove it easily. This is how to manage a patient with a mistaken tube. So when endoscopy available, the endoscopy is looking for if there is any esophageal varix only, or esophageal varix with fundal varix, or fundal varix only, and in case there is what we call it portal hypertensive gastropathy, or for a rare condition but available in Sudan here like an ectopic varix. This is the feature of esophageal varix in upper GI endoscopy, and there is a lot of classification, but one of these classifications is called backward. It depends. In grade 1 there is no varix, grade 0 no varix, grade 1 small microvarix, and grade 2, 1 to 2 or even 3 small varices. Grade 3 is a medium size, and grade 4 nearly or totally sometimes as if it including the lumen. And in this picture, I would like just to show you something that this red spot and this white one, this is called red spot sign, and this is called white nipple sign, and all of this is a sign of recent hemorrhage. The other one for the gastroesophageal varix and isolated varix, this is by Sarin classification, which depend on type 1 gastroesophageal is in the lower esophagus with the lesser curve, or the lower esophagus with the greater curvature is type 2. And for isolated gastric varix, type 1 is the fundal, and type 2 in the area of the pre-pyloric and pyloric region. So this is how the varix is looking, either in elective case or in emergency by a bleeding, or in the case of the fundal varix, and when we do retroflexion or J maneuver. And this is in a case of sigmoidoscopy, we found what we call it rectal varix. And this is in the duodenum as a feature of ectopic varices in the duodenum. Other thing is you can scope the patient and he has hematemesis or melena, and you have and this patient have low hemoglobin. When you scope, you found neither esophageal varix nor fundal varix. Just you see like this picture hyperemia and cracking of the all mucosa. This is called hypertensive gastropathy. So if you just ask ourselves question, variceal ligation versus variceal sclerotherapy. The answer is that band ligation was associated with the lower rates of rebleeding and mortality. But endoscopic injection sclerotherapy is an essential component in the management of bleeding esophageal varices that caused by portal hypertension. It is a feasible and cost-effective therapeutic strategy in developing countries, especially in Sudan, and even in the bleeding center. We thought that despite the band is better, but if you just give an example, you insert the scope and you found the patient is active bleeding with the spertal. If you can just insert the cannula and inject it directly. But if you would like to do a band, then you have to withdraw the scope, asking for the band, connecting the band, and then re-scope the patient again. And sometimes we see that the area becoming very bloody, and even I cannot detect the site of the bleeding. So despite band ligand is better, we like to use sclerotherapy. So in case of sclerotherapy, we have either to do intravaricial injection or paravaricial injection. The intravaricial injection is better. It prevents the future stricture, or what we call it, post-sclerotherapy stricture. But sometimes, if you have an active spertal and you try to inject intravaricial, but the blood cannot stop, then you have to inject paravaricial. This will act as a tamponade to stop bleeding. This is just a small video for a patient, did for them endoscopy, and this is the retroflexion. This is the fundal area, and as we see in the fundal area, there is lots of fundal varices, dilated veins with a small red spot sign that indicate this patient have or had an acute bleeding at the moment or bleeding loss from a small area, and this patient might need need injection by cyanoacrylate, what we call it in Sudan is as histoacryl. This is another patient, and if you can see, he has a very big fundal varix with a sign of recent bleeding and containing some portal hypertrophy. And this is the needle injected. We like to inject it in the base of the fundal varix. We inject with cyanoacrylate, usually 2 ampoules containing nearly 2 ml. But sometimes, in the case of very big varices, you might need to inject more than 2, like 4 or even 6 ml from histoacryl. Sometimes when you inject, and after your injection by histoacryl, we prefer to keep pushing on the side of the needle, because when you try to pull it out, bleeding can come from this side. Just keep it for a while until the bleeding stops. But for this patient, he might need another 2 ampoules of histoacryl. Look for the needle when it's removed. You see now some blood came from the site of injection. Like this one, it can be stopped, but to be in the safe side, better to inject another. The problem of histoacryl that the needle clotted or occluded, so you have to change the needle by another new needle and reinsert again to the scope to insert this bleeding. Another needle with another 2 ml histoacryl injected to the base in another area. After injection, just press over for a while before you remove the needle. And then after you withdraw it, bleeding stop, and the injection is successfully end, but this patient need to come after 2 weeks for another session of injection. So about 80 to 90% of acute variceal bleeding episodes are successfully controlled by endoscopic therapy. And nearly 10 to 20% of patients of acute variceal bleeding is not controlled and known as refractory variceal bleeding. So what to do in a case of a refractory acute variceal bleeding? The answer is transjugular intrahepatic portal systemic shunt is highly effective in this situation. And early tips should be considered in a patient at a high risk of treatment failure after initial endoscopic and pharmacological therapy. And if bleeding cannot be controlled, there is what we call it expandable cover esophageal stent may be considered in patients with variceal bleeding refractory to conventional therapy. But surgical procedures are employed less frequently with the development of endoscopic therapy and tips. Although surgical procedure can effectively control variceal bleeding, the mortality remains high, nearly 50% plus or minus, and hepatic encephalopathy is a major complication after shunt procedure. Compared with tips, post-operative complication and survival after surgical shunting were superior for patients with portal hypertension. An application of surgical shunt was recommended for patients rather than tips. So tips indicated if the patient have a multiple episode of variceal bleeding or a refractory variceal bleeding, or in the case of refractory ascites, it inserted through the internal jugular to superior vena cava through the heart into the inferior vena cava, and then connecting the portal with the hepatic vein. And it's contraindicated totally or absolutely in the case of primary prevention of variceal hemorrhage, or in the case of congestive heart failure, or in severe pulmonary hypertension, and those with severe tricuspid rigor, or active biliary obstruction, and sepsis, all multiple hepatic cysts like Caroli disease. Relative contraindications in some cases of hepatocellular carcinoma or moderate pulmonary hypertension, or case of portal or hepatic vein thrombosis, or in the case of severe coagulopathy or thrombocytopenia, and for sure, severe encephalopathy. Other presentation is hepatorenal syndrome, and it defined as a functional renal failure in a patient with liver disease with a portal hypertension. And morphologically, there are intact kidneys, and the regulatory mechanisms have minimized glomerular filtration, so there is reduced GFR, and maximize the tubular resorption and urine concentration, so it ends up by uremia. And it is very common in those patients with portal hypertension with ascites. And it is two types. Either type 1 hepatorenal syndrome, it developed as a consequence of severe reduction of effective circulatory volume due to both extreme splanchnic vasodilatation and reduce in the cardiac output. It characterized by, or it has a feature of rapid and progressive renal impairment. The other type 2 is characterized by stable or slowly progressive renal failure that associated with the refractory ascites. And the treatment is the correction of hypovolemia, and some patients we need to increase the vascular, the vasospasm or vasoconstrictor, with increase the intravascular volume by, for example, combination of terlipressin with albumin or epinephrine with albumin, or if the patient develop a renal failure who might need continuous venous hemodialysis, or in the severe case, we can move to TIPS or even liver transplant. Other presentation is hepatic encephalopathy, and it's defined as a spectrum of neuropsychiatric abnormalities in a patient with liver dysfunction, and we should to exclude any previous brain disease. And it's caused by effective neurotoxic substance like ammonia. And ammonia has a multiple neurotoxic effects. It can alter the transit of amino acid, water, and electrolytes across the astrocytes and neurons. It can impair the amino acid metabolism and energy utilization in the brain. And also it can inhibit the generation of excitatory and inhibitory postsynaptic potential, and this is why ammonia play a major role in hepatic encephalopathy. And the types of hepatic encephalopathy, it's very easy. In type A is hepatic encephalopathy that describes encephalopathy associated with acute liver failure. So type A is with acute liver failure. And type B hepatic encephalopathy is associated with the portosystemic bypass and no intrinsic hepatocellular disease. So B with bypass. And type C hepatic encephalopathy is associated with cirrhosis and the portal hypertension or portosystemic shunt. So don't forget C with cirrhosis, and it's further subdivided into episodic or persistent or minimal, and this is not our issue now. The precipitating factor, if you look for this big table, it's lots and lots. Just I'm going on it quickly, starting by if patient have a GI bleeding, they might precipitate encephalopathy, for sure constipation or renal failure, and in case of blood transfusion, or metabolic abnormality like hypovolemia, hypokalemia, metabolic alkalosis, hyponatremia, and hypoxia, hypotension, or anemia, or hypoglycemia, or in case of increased systemic stress like infection or post-surgery, and of those patients for sure with portosystemic shunt, either surgical or non-surgical like shunt, or medication like sedative or any drugs that lead to sedation or sedative for the brain, it can precipitate hepatic encephalopathy. So grade of hepatic encephalopathy based on West Haven criteria, it ranges from grade 1 to 4, and grade 1 is sleep reversal. Those patients awake all the night and the day are they're sleeping with a mild lack of awareness. And grade 2 is lethargy or poor memory or personality change. Type 3 is somnolence, confusion, or even disorientation. And grade 4 is stupor or coma. So treatment of encephalopathy is based on the grade of encephalopathy. So in a case of minimal encephalopathy, this is used by diet control, avoiding high protein diet, an antibiotic like rifampicin or neomycin, with the lactulose and enema to reduce ammonia and sterilize the bowel from bacteria. And for sure to avoid all precipitating factor of encephalopathy that mentioned before, and to avoid medication that depress central nervous system function. And sometimes patients with grade 3 or 4 encephalopathy might need a prophylactic intratracheal intubation because those patients are more prone to develop coma at this stage. The other presentation is splenomegaly, and it's enlargement of the spleen that caused by a decreased blood flow through the splenic vein. And as we know, due to portal vein, due to prehepatic cause or hepatic and increase the portal pressure, this will lead to reduce the splenic vein blood flow, and this is will result in backflow of the blood with enlargement of the spleen, and this decrease the ability of the blood to drain from the spleen that cause it to become congested and grow larger. And usually this patient might end by hypersplenism, which is a clinical syndrome characterized by splenomegaly, pancytopenia for all or some of low hemoglobin, white blood cell count, or low platelet, and usually associated with hyperplasia of the precursor cell in the bone marrow, and confirmed by bone marrow aspiration to find the hyperactivity of these precursor cell, and usually splenectomy might be done for asymptomatic pancytopenia. So to assess the severity and mortality for all patients with the portal hypertension, they developed a lot of scoring system to assess the severity and mortality. Just I mentioned two of them. The first one is the child Turco-Tough classification, which have 5 clinical and lab criteria: encephalopathy, and ascites, and bilirubin, and albumin with a bleeding profile, either BT or INR, and scoring or pointed between 1, 2, and 3. For example, encephalopathy, if there is no encephalopathy, this is pointed 1, and if there is grade 1 or 2, this is 2, and grade 3, this is 3 and 4, and the same like for ascites or bilirubin, less than 2, and 2 to 3, this is 2, and more than 3, this is grade 3, and albumin, if it is normal more than 3.5, this is 1. If it's between 2.8 to 3.5, this is 2. If it is less than 2.8, this is 3. And the INR, for example, if it's less than 1.7, this is 1. Between 1.7 to 2.3, this is 2. And if it's more than 2.3, this is 3. And it's grade like class A, B, C. A is 5 to 6 points, and B is 7 to 9 points, while C is 10 to 15 points. This can simplify the patient that can be classified in this stage to know the prognosis and mortality. The other one is called MELD, which is stage for model for end-stage liver disease score system. It is easy classification to assess the severity of chronic liver disease and the priority for liver transplant. It composed of continuous venous hemodialysis and creatinine and bilirubin and INR. And recently, after the year of 2016, sodium is added to this classification. So some patients, they said that this is MELD sodium, or other one said this is MELD score. And just you have to fill the data directly, and automatically the system will give you the result. And this patient with MELD score 17 or greater are considered candidates for liver transplant, and those with a score less than 15 is deferred from liver transplantation. Generally, the MELD score, if the MELD score less than 9, the mortality is nearly 1.9%, and if it's more 40 or more, the mortality is 71.3%. And if you just compare between child, Turco-Tough, or MELD score, we found that the child Tough score can predict mortality or removal from the liver transplantation waiting list better than MELD score over a 9-month period. To investigate patients with a portal hypertension, start by simple investigation like complete blood count, looking for the sign of anemia or white blood cell count low or thrombocytopenia. And in case of the liver function test, for sure, looking in the case of liver rearrangement for the enzymes of serum bilirubin, and the real profile, looking for the case of hepatorenal syndrome, INR for the case of bleeding, like that, fire screening to exclude the primary causes of cirrhosis if it's the case of hepatitis or others. And the simple measure is ultrasound that detects the portal venous diameter dilatation if there is any varices. Another one like a CT and MRI, but it's not common use in Sudan. We use the simple one, ultrasound. Hepatic venous pressure gradient theory, it's a little invasive and not commonly used here. And for sure, upper GI endoscopy and colonoscopy, looking for the varices, either esophageal varix, fundal varix, or rectal varix. This is just simple an ultrasound showing the dilated portal vein more than 13 millimeter. This left portal vein and main portal vein. This is the CT angiography looking for the main hepatic veins and tributaries. And this is MRI angiography with all venous system very clear. So the plan of management for patients with portal hypertension usually start by medical treatment in case of patient as an elective patient or patient with emergency. And for those patients with elective, usually we like to give a beta blocker in a form of 40 milligram OD or even twice by day. And frequent, usually those patients we have to stop for regular endoscopic pant ligation or sclerotherapy. And if there is any ascites to manage, or if to guard or to treat hepatic encephalopathy, and if there is any hepatorenal syndrome, moving if failed all these measures to tips, and then to have ask our question, either conservative treatment versus surgical management. Overall, the role of surgery in bleeding portal hypertension has changed dramatically in the last few decades. And despite some rule for surgical shunt, this has been markedly reduced. And the emergent setting, surgery is rarely needed now because there is a lot of intervention endoscopy that can stop or even treat variceal bleeding in the last few decades. And far from becoming obsolete, surgery in its various forms continue to have a place in the management of variceal bleeding due to portal hypertension. And surgical management, if just go quickly over it, it's either a non-shunt operation or shunt operation. And starting by a non-shunt operation that composed of devascularization, splenectomy, with or without esophageal transection. And the commonest two examples is HASAP or modified HASAP operation and Segura or modified Segura operation. HASAP operation or modified HASAP operation, it's a procedure started in 1967, and it includes splenectomy, devascularization of the lower esophagus and the upper half of the stomach, with ligation of the left gastric vessels, commonly used in Sudan. And the modified HASAP operation is an effective procedure for the treatment of portal hypertension. While Segura or modified Segura procedure had started in 1973, at that time, it's a very big operation, the Segura, it composed of two approaches. The first approach is thoracic approach, going through the thoracotomy to do extensive devascularization of the whole esophagus through the thoracic opening. And after 4 weeks, for example, then we have to go for another abdominal approach with a laparotomy, followed by splenectomy, and to complete the devascularization of the lower esophagus and the proximal half of the stomach with the ligation of the left gastric vessels and esophageal transections through a small gastrotomy tube and then stapler. And for sure that the guy at that level will be cut, and then we have to do a pyloroplasty. But the modified one is only one approach through the abdominal approach to move through the hiatal area to do as long as devascularization of the lower esophagus, followed by proximal half of the stomach and splenectomy with ligation of the left gastric vessels and transection with pyloroplasty. The other type of surgery is a shunt operation. We have a total and partial. Total shunt like a selective or a non-selective. And if you just move to a non-selective shunt operation, many types, and the commonest one is portocaval. And portocaval, if we look for this second diagram, we see it is either a side-to-side portocaval shunt or end-to-side portocaval shunt. And the problem of this shunt is that the surgeon is working on the field of support hepatitis, and if the patient is planning forward for liver transplantation, the area becomes fibrotic and the transplantation becomes very difficult. Other option is mesocaval, which could be again side to side or end to side, and the proximal splenorenal or Lenton shunt, and all of these has a high rate of encephalopathy, so it's not more than used a moment. The other selective one is a distal splenorenal. Just we disconnect the splenic vein and connect it directly to the distal part of the renal vein. It has a less encephalopathy. And the partial one, in this partial, we use a graft or autogenous vein with a diameter not more than 8 to 10 millimeter, and this will reduce the flow from the portal, for example, to the cable, or from mesentery to the cable, and the aim of this small one to reduce the amount that containing toxin material to go directly to the circulation. The autogenous venous, usually we use a graft, autogenous graft from, for example, inferior mesenteric vein or anyone. Then it's just grafted between the splenic and the splenic and left renal vein or any portal with the cable. If you compare all these measures, intervention for bleeding esophageal varix, just if we're looking for HACCP, the rebleeding rates is nearly 6 to 8%, and the most common complication is gastric outlet obstruction, because sometimes incidental both vagi can be cut. Or Segura, the rebleeding time is 10 to 26%, and associated with esophageal leak or stenosis, or sometimes portal vein thrombosis. And in case of endoscopic sclerotherapy, the rebleeding rate is nearly 20 to 50%, and usually associated with systemic embolization, while in TIPS, there is 20 to 50% rate of rebleeding, and those patients have stent stenosis, thrombosis, or for sure hepatic encephalopathy, while for distal splenorenal Warren shunt, the rebleeding rate is nearly 0 to 11, and the most common complication is shunt or mild encephalopathy. So, ending up by all this, the best option for treating those patients with portal hypertension is liver transplantation. It's all the curative treatment for patients with a portal hypertension in end-stage liver disease. And regarding the current local data from Sudanese area under publishing, honestly, a lot of theses done in this field in Sina Hospital. I will just go quickly to review 3 of them. For example, the MD thesis by Wala El-Hadi, she's talking about risk factor and predictors of variceal rebleeding in schistosomal portal hypertension patient at bleeding center in Sina Specialized Hospital. She concluded that in patients with schistosomal portal hypertension, drop of hemoglobin at presentation, variceal grade, chronicity of schistosomiasis, and hypertension were predictors for occurrence of variceal rebleeding, and furthermore, smoking is a high risk for rebleeding. The other one is by Dr. Aladdin Abu Ubaida. He's talking about comparison between endoscopic sclerotherapy and band ligation for hemostasis of variceal bleeding at National Center for Gastrointestinal and Liver Disease in Sina Hospital. He concluded that treatment of esophageal variceal bleeding with a band ligation has a lower rates of rebleeding, and chronicity of portal hypertension and the presence of shock at presentation appears to be significant risk factor for rebleeding after both procedures. And the last one is by Dr. Nassir. She about acute esophageal variceal bleeding in Sudanese patients, a study of 1,047 patients in a single specialized center in endemic area. She concluded that the common cause of upper GI bleeding in Sudanese patients is bilharzial portal hypertension, and sclerotherapy and band ligation with the terlibricine injection were important in cessation of bleeding. So, dear Chairman, dear Professor, dear my colleague, I would like to conclude that the prevention of variceal formation and variceal bleeding is of great importance, and the treatment of acute variceal bleeding is based on bleeding variceal esophageal varix or fundal varix, or if it's ectopic varix or portal hypertensive gastropathy, and usually preventing recurrence of variceal bleeding will reduce the mortality. And this treatment modality by pharmacological therapy, a lot of them can be used, but as Splanchini, for example, we use terlibricine or vasopressin, and inhibitory hormone, somatostatin or octreotide, and the best common one is a beta blocker like a propranolol. An endoscopic treatment, sclerotherapy versus endoscopic variceal ligation, I prefer honestly on stopping the active spertal by sclerotherapy, and then can be followed by ligation. And if failed, to go for syncytial tube, and in the case of difficult, either interventional radiology by tips or covered expandable esophageal stent for variceal tamponade action. Surgery for esophagogastric devascularization by Segura or modified Hassab operation, and in Sudan the commonest is Hassab procedure. And the non-selective in the form of side-to-side portocaval or mesocaval or spleno shunt, and the selective one by a distal spleno or small diameter interposition of H graft, for example, autogenous or any artificial, can be used. And the best of these, all of these measures is liver transplantation. Thank you for attention. Thank you for attending this lecture.
Thank you very much, Mr. Nassir Alhaboob, for this outstanding and very informative presentation in this very chilling topic. On behalf of Professor Muhammad Ahmed Ibn Auf, I think it faced a lot of obstacle internet connection. It is really very happy today. I'm very glad to welcome all of our seniors, our professor, Professor Abdul Majid Muhammad Musaad, Professor Rashid Ahmed Abdullah, Professor Muhammad Al-Muhtasim, Professor Sulaiman Hussein. Now I think Professor Ibn Auf is with us. You are welcome, Professor Ibn Auf. You are welcome, Professor Ibn Auf. I think Professor Ibn Auf has a lot of obstacles in internet connection. Now his floor is open for our seniors. Professor Rashid, Professor Sulaiman Hussein, Professor Abdul Majid, Professor Abdul Rauf Ahmed Sherfi. You are welcome, all of us.
Assalamu alaikum wa rahmatullah. In fact, someday anyhow, thank you very much, Mr. Nassir, for this elegant presentation, comprehensive presentation. Also, I would like to welcome
I think again a lot of obstacles in internet connection. You are welcome, Professor Ibn Auf. You are welcome.
I think there is a lot of problems in the internet colleagues. Abdul Majid Musaad, Abdul Rauf Sherfi, Professor Sulaiman Hussein, and the rest. And for the school fact, really all the thanks goes to Mr. Muhammad Saad Saleh Idris, who has started to go to specialized bleeding centers, and we're happy in Khartoum we have one. And also the thanks goes to Professor Suleiman Saleh Fidel, who invited Mr. Muhammad Saleh. Now the floor is open for discussion. In fact, I have a problem with the camera, probably. You can see who.
Okay, the floor is open now. Professor Suleiman Hussein, you are welcome.
Thank you very much, Nassir, for a very elegant presentation that
My camera is
covered most of the clinical aspects of portal hypertension, in particular in relation to Sudan. I think you covered most of the topic, but there are some comments in particular for our junior registrars and junior specialists. I think the importance of resuscitation of such patients. And those patients, usually when they present with severe hypovolemia. And endoscopy is not the answer. I think that the tips for resuscitation of such patients who are usually hypovolemic, having some degree of encephalopathy, they are having some degree of coagulation derailments. I think you have to spend some time on correcting those problems before you send the patient to the bleeding center. And very unfair to send a hypotensive patient for endoscopy, very unfair to send the patient with coagulopathy for the bleeding center. So resuscitation is very important, and there are certain tips in resuscitating patients with varices, which are quite distinct from other bleeding patients. So these are, I think, these very important. The other point, as Nassir clearly presented, is that rarely now we need to operate on such patients. And in the night, I think our colleagues, Abdel Majid and Professor Rashid, and they may remember that in the 80s, we tend to operate in the middle of the night for bleeding varices, but this is very rarely happening. And the role now for endoscopic treatment and intervention radiology is well established now. And another point regarding our country, I think also we shouldn't be carried away by the management, by the fancy aspects of management. You have to remember that if some of you may remember the Blue Nile Health Project for eradication of bilharzia. And I think this is the cheapest way of treating portal hypertension in this country. And I think we have had, if you look at the epidemiology of the disease, we may find that till the bilharzia is almost disappeared. And we rarely see patients with bleeding varices in the 1980s, 1920s because of the successful program of eradication of bilharzia. But now, unfortunately, bilharzia is back again. And we are seeing now it is quite endemic, not in Jazeera, but in certain suburbs of Khartoum. So probably, yes, when we see patient as a clinician, we see patient down the road when they develop portal hypertension. But we shouldn't forget in this country to emphasize the role of prevention. And now we are back to mass treatment of bilharzia in the schools and in the community. So this is another important point I think we have to not to forget when we talk about portal hypertension. But thank you very much, Nassir. I think we enjoyed your talk. We learned a lot from your presentation. Thank you very much.
Professor.
Thank you very much, Professor Suleiman Hussein. Now the floor is open for all of our participants, our seniors. Anyone have any comment or any question or any query, please unmute yourself and ask directly. Professor Ibn Auf, you can unmute yourself. I think we have question, Mr. Nasir from Dr. Hatim. First, he thank you very much. Then he asking refractory esophageal.
Yes. A controversial subject. Sometimes any bleeding, but he has also esophageal. Is the voice clear?
نعم تفضل.
Is the voice clear?
نعم تفضل.
Yeah. Sometimes we find during endoscopy patients with esophageal varices, and they had never had a past history of bleeding. And some of them, they come from remote areas. Is it justifiable to do a preventive sort of injection sclerotherapy or rubber banding?
Unfortunately, we lost the contact with Professor Nawaf for the second time. Professor Sulaiman, if you have any addition.
I think Professor Abnaf is want to ask about primary prevention, endoscopic primary prevention for patients with non-bleeding varices. And I think the data is showing that those patients, in particular those patients with large varices, grade 3 and grade 4, the incidence of bleeding is very high. So those probably are the patients who are candidate for primary prevention by rubber band ligation, even if they haven't had any history of bleeding. And another comment about the published data locally. From Toba University Hospital in the 80s, I think we published this. We have had the same result of what came up from the National Center. We published about the splenectomy and devascularization, and the results were almost similar. The problem of splenectomy and devascularization, the HASAP procedure, is a high rate of free bleeding. You stop the bleeding at the same time, but the high rate of free bleeding rate. And the predictors for rebleeding are almost the same about the status of the liver and the size of the spleen, and if I remember well. So it is almost a reproducible figures in the 80s and recently from the National Bleeding Center. The same data and the same outcomes. Of course, we are dealing with the same disease.
Yeah, Mohammed, can you hear me?
Yes, please. Mm-hmm.
Yes, well, thank you, Nassir. I think this is very impressive. But sorry, the interruption for the internet. I probably attended only 25% of your presentation, but it was really definitely very impressive, especially the first few slides stating the basic anatomy and physiology. My question is that, is it still esophageal varices the number one cause of bleeding in the Muhammad Saleh Idris Center? Is it still the first one? And I like a comment of Mr. Silam, because the Blue Nile project, I think, stopped, but the Praziquantin project for prevention, I don't know what's going on, but the Egyptians are now able probably to get rid of most of this. You don't see any publication about esophageal varices and bleeding from there. Well, just remember the good old days, as Mr. Suleiman just mentioned. I mean, the HASAP operation. I remember Professor Shawki, rahmatullah alayhi, his comments was that I think he is the one who did most of the HASAP probably at that era. Those patients, they come fatigued. He said all these farmers are unable to go back to work. It is just a syndrome. I remember he was talking about this. Even those who don't have any bleeding, but they still are not really coming back to society as a functioning person. I don't know whether you have got any impression. And what about the long-term data of this? I mean, you said 90% of taken, this is the success rate. But is it being well followed, these patients? I mean, for how long you don't have any extra bleeding? And what is the rate of these complications of stricture and probably fistula? Very few fistula, but I mean, how much complication post-injection sclerotherapy you have? Because I mean, people, they don't do it now. They do just rubber band, but as you mentioned, this is cheap and probably suitable for our society. But thanks, Nassir. I think it's very good, well presented, and very educating.
شكرا بروفيسور رشيد. حقيقة عاوز أجاوب على النقطة الأولى اللي هي regarding the rate of esophageal varices in bleeding center محمد صالح إدريس. From observational study, we found that the majority of bleeding who present to Muhammad Saleh Idris Bleeding Center in Sina, the majority of them, more than 75 or 80%, is due to esophageal bleeding, either in the case of active bleeding hematemesis, and in another study done by Dr. Fatma regarding the major cause of lower GI bleeding in Sina Bleeding Center, she found that nearly 50 to 60% of those patients who come with fresh rectal bleeding, the cause is primarily from esophageal, active esophageal bleeding. And this is why the majority of them.
And the number of cases, probably per week or per month.
Okay, Muhammad Saleh Idris received nearly every year between 2,000 to 2,200 bleeding patients. Nearly about 1,500 to 1,800 is esophageal bleeding. Minority of them is due to.
Do you have any data from Jazeera, Managil, and Madani? Probably load of.
I have no idea from Jazeera or Managil regarding the real status, but who is present to the institute? The majority of them is esophageal bleeding, esophageal varix, with few patients due to other causes like a peptic ulcer or like anything else.
Regarding the data from
لحد الصوت مرجع. الحاجة الثانية اللي لاحظناها
محمد صالح إدريس Center, I think there are about, I do remember one of them by, I think there is some applications from. Also, I would like just to speak about 2 points. During emergency, we use vasopressin. Vasopressin, it acts on arteries to reduce the inflow in the portal venous system. It causes vasoconstriction to reduce the inflow into the portal venous system. While during the elective phase, we just give the beta blocker propranolol at home and use it because it reduces the venous blood pressure. So one drug for arteries and in emergency, and the other to reduce the venous pressure in the elective period. Now, for the different types of surgeries, still HASAB comes first, and surgery comes first because and its outcome, at least in the hands of surgeons who operated in the Sina hospital, is good. Very few cases they go for surgery by endoscopy, by sclerosis. However, in the past, they used to do one shunt, distal hepatorenal, but because it is an anastomosis between 2 veins, the renal vein and the splenic vein, the flow between these 2 veins is a sluggish sort of flow, and it induces high rate of thrombosis. This is the main problem of Warren shunt, and I think it is coming out. And the only thing in the dire emergency, when endoscopy fails, then I know here in Sudan. However,
طيب لحد ما يرجع
very few cases nowadays they go for surgery, in spite of thousands and thousands of Saleh Idris Center.
طيب نستغل الفرصة معانا الأساتذة الأفاضل.
Anyone else would like to comment or
I would like to add point. نستغل الفرصة معانا الأساتذة بروفيسور ابن عوف، بروفيسور عبد الماجد، بروفيسور رشيد، بروفيسور سليمان حسين, and all colleagues and junior colleagues. We noticed that some practice that can be in the lots of hospitals. Honestly, does there is any indication for a splenectomy in all patients with portal hypertension? We notice that in the bleeding center, there is nearly 10% of the patient who is come have a recent splenectomy or HASAB operation. So my advice that please, not all patient with a portal hypertension is a candidate for splenectomy or HASAB operation, because if there is still the cause of the bleeding with varices found, the patient will bleed. And we saw patients on day one postoperative refer from the Asper hospital with a bleeding following HASAB operation. So not patient, all patient can candidate for splenectomy. And please to notice that if the patient is child A, he might go to child B, and if he is child B, he can move to child C. So please select your patient if you are going to HASAB or splenectomy for those patients with portal hypertension. The other point, just I would like to comment that some patients go to the peripheral hospital with the symptom or sign of hemorrhoidal bleeding, and the surgeon believes that this is just a simple hemorrhoid, and when he operating, a lot of bleeding can occur. And please, if you have a patient with suspected portal hypertension, kindly just do a simple sigmoidoscopy looking for the rectal varix. And if in the case of the rectal varix, this is totally differently treated from the hemorrhoidal one. The other a little difficult point is to operate in a surgical operation for a patient with a portal hypertension. For example, if those patients have, for example, common bile duct stone or gallbladder stone in a portal hypertensive patient, I think this is another point we have to just to stop and look for it, because we notice that those patients, for example, with portal hypertension and have a gallbladder stone or CBD stone, they have sometimes bleeding intraoperative, and some patient can move from child A to child B or B to C. So this is another point, just if you would like to cooperate on, please sit down and then have a look for possible complications that can occur.
Prof. Sulaiman, if you have any comment. The floor is open for any comment or any question. Please don't hesitate to unmute yourself and ask your question or any query. Prof. now.
I would like to add a comment. I would like to add one comment to Mr. Nassir comments, and that what I noticed before, and I think till now it is going on, they come right in shock to the center. I think whenever a patient is referred, at least 2 or 3 units of blood to be
We lost again the connection with Professor Naaf. The floor is open for any question or any comment. You're welcome
a
again.
lot of internet disconnections.
Okay.
Yeah. I was saying that lots of patients who is referred, it is better to be
We are really sorry for this disruption in internet connection. and we hope to connect with Prof. Ibn Auf soon. Anyone have any question before to close this very informative session? Prof, you are welcome.
Hello.
Okay, you are welcome.
Hello.
اتفضل يا بروف.
Hello.
ايوه.
Prof. Suleiman, if you have any comment.
Just to reemphasize the point that nowadays I can't find any excuse for patient to have surgery or portal hypertension without exhausting the chances of having endoscopic treatment. And now there is endoscopy units in most of the big cities, in Al-Ubaid, in Al-Fashir, most of the Jazeera, in Adbara, in Al-Qadarif, and I think most of the cities now, there is a good endoscopy units, and most of them, they are doing injection sclerotherapy plus or minus rubber band ligation. So I think the message is that yes, splenectomy and devascularization indication is very limited now. And I think the message is that, yes, we have to exhaust all the endoscopic therapy. And if we do that, I think we rarely we need to operate on such patients here. Emphasize also point muhimma jiddan, mentioned by Mr. Nassir, is a selection of patients if you need to operate. It used to be that you shouldn't operate on patients with child B and C, because those patients usually they do very badly, and that was that which was published repeatedly. So the chances that if you want to select a patient, a young, well-fit patient with a child A, probably the only indication now for elective surgery in patients with portal hypertension is symptomatic hypersplenism. If somebody is having symptomatic hypersplenism, pancytopenia, epistaxis, prolonged bleeding time, probably this is the only elective indication now for surgery in patients with portal hypertension. Other points I think it's very important mentioned by Nassir is that patients with portal hypertension who present with other surgical problems. This also shouldn't take it easy. I think those patients should be managed by very senior input from senior surgeons. Even a simple gallbladder surgery may be a nightmare if the patient has got portal hypertension.
Professor Rashid.
Yes, I agree with you, Mr. Suleiman, that the indication for probably a huge spleen. I remember a young girl coming with a huge spleen in a village that people are thinking she's pregnant and causing discomfort. So this is very limited. But I agree. I mean, asymptomatic hypersplenism after the physician get probably his work, because some of these patients might be probably able to work with a low hemoglobin of 70 or 60 something. So even this probably, and it has to be really based on. But I mean, very, very interesting. I mean, the change of practice over the years for our young residents. I mean, when we are registrars, I mean,
If no more question, on behalf of all senior and junior in the Sudanese Surgical Club, it is really great honor to thank Mr. Nassir Alhaboob for this very elegant and informative session, and we hope to see you in the future in the future soon. Much Mr. Nassir, and we hope to see you soon.
شكرا لك محمد، شكرا رامي، شكرا لكل الحضور، ونتمنى نشوفكم مرة ثانية و have a nice weekend.
Thank you very much, Mr. Nassir.